Welcome. In today's lecture, we're diving into the fascinating world of dissociative disorders. It's a category of conditions that challenge our understanding of identity, memory, and perception. These disorders sit at the intersection of trauma, neurology, and psychology, making them one of the most complex and debated areas of mental health. While dissociation itself is a normal phenomenon, so just think about zoning out while driving or daydreaming through a boring meeting, when it becomes persistent, disruptive, or linked to trauma, we start entering clinical territory. Today, we're going to break down the diagnostic criteria, explain how these disorders show up in real life, and discuss the ongoing controversies that make them a hot topic in clinical research. We'll also talk about differential diagnoses because, let's face it, these disorders can look a lot like other conditions, and misdiagnosis is common. And finally, we'll tackle treatment conditions, including what works, what doesn't, and what ethical dilemmas therapists face when working with dissociative clients. By the end of this lecture, you'll be able to define dissociative disorders and identify their core symptoms, understand the DSM-5-TR and how it differs in classification of dissociation from the ICD-11, evaluate contemporary research and debates, especially surrounding dissociative identity disorder, or DID, which is probably the most controversial diagnosis in the DSM right now. You'll be able to critically examine cultural and clinical bias because not every culture views dissociation the same way. And diagnostic frameworks are often shaped by Western psychiatry. You'll reflect on broader clinical implications. What does all of this mean for treatment, ethical practice, and client outcomes? And here's where you come in. Again, this isn't just a lecture, it's a conversation, and I encourage you to write comments, share your insights, or ask questions as we go. If you have a strong opinion on dissociative identity disorder, say it. Are you curious about how dissociation intersects with other disorders? Or if you want to challenge something I say, go for it. The best way to engage with this material is to think critically, and I'd love to hear your thoughts. So let's get started. So starting with dissociative identity disorder, or DID, it's one of the most complex, misunderstood, and debated conditions in psychiatry. It's characterized by the presence of two or more distinct personality states, sometimes called alters, that take control of a person's thoughts, behaviors, and emotions at different times. These identity states can have different memories, personal histories, speech patterns, even physiological differences such as variations in handedness or allergic reactions. DID is often accompanied by significant amnesia, affecting personal history, daily events, and traumatic experiences. Unlike ordinary forgetfulness, these memory gaps reflect a deep disruption in the continuity of self-awareness. The DSM-5-TR outlines the diagnostic criteria for DID as the presence of two or more distinct identities or personality states which may be observed by others or experienced internally by the individual. Recurrent gaps in memory, which can go beyond normal forgetting and affect daily life, personal history, and traumatic events. Significant distress or impairment in important areas of life like social or occupational. And symptoms cannot be attributed to substance use, medical conditions, or culturally accepted religious experiences. So you might want to think about maybe possession states with some religious practices. DID is frequently linked to severe childhood trauma, particularly repeated physical, emotional, or sexual abuse. And many theorists, including Bethany Brand and Colin Ross, propose that DID develops as an extreme coping mechanism, a way for a child to survive overwhelming experiences by mentally compartmentalizing trauma into separate identity states. This allows the individual to function by keeping painful memories out of conscious awareness. There is no single cause of DID, but like I just said, multiple theories attempt to explain its origins and mechanisms. So what I just talked about is the trauma model. DID is seen as a post-traumatic developmental disorder where chronic trauma disrupts identity formation. When a child cannot integrate overwhelming memories into a cohesive self, separate identities form to contain and manage the distress. The iatrogenic model argues that DID is therapist-induced, emerging from suggestion, hypnosis, or leading questions. In this view, vulnerable individuals may internalize dissociative identities through expectation and reinforcement rather than actual trauma. There's also neurological evidence. Brain imaging studies show that different identity states have unique neural activation patterns, particularly in regions related to memory, self-referential processing, and emotional regulation. Some alters even display distinct brainwave activity and physiological responses. And then we can also look through the lens of schema theory. Alters may develop unique cognitive and emotional schemas, shaping their worldviews and behaviors independently. This aligns with theories of cognitive compartmentalization, where each alter functions based on its own set of conditioned responses. DID remains one of the most contested diagnoses in mental health. Some clinicians and researchers fully accept it as a trauma-based disorder, while others view it as cultural or iatrogenic construct. Here are a few of the most common debates. Is DID real or created? Some argue that DID is socially reinforced through media, therapist expectations, or misinterpretation of symptoms. However, evidence from brain imaging, case studies, and longitudinal trauma research supports its legitimacy. And then there's DID in the media. Movies like Split and Fight Club depict DID as a disorder linked to dangerous or violent behavior, which is highly misleading. The vast majority of individuals with DID are not violent and are more likely to be victims of trauma rather than perpetrators of harm. There's also misdiagnosis concerns. DID is often confused with borderline personality disorder, bipolar disorder, or schizophrenia. Unlike schizophrenia, individuals with DID have intact reality testing. They may struggle with internal voices like alters, but they do not experience fixed delusions or external auditory hallucinations. Because DID shares features with several other disorders, accurate diagnosis is critical. Some key distinctions include looking at PTSD versus DID. So both involve trauma, but PTSD does not include distinct identity states or amnesia for personal identity. With schizophrenia, individuals lose touch with reality, whereas those with DID remain aware of their dissociative experiences. Bipolar disorder involves mood swings that follow a pattern, whereas DID identity shifts are often triggered by stress or trauma reminders. And factitious disorder or malingering, that one's in the other lecture that we're covering this week if you haven't listened to it yet. But people who malinger or feign symptoms for secondary gain, like maybe legal reasons, tend to have stereotyped, exaggerated identities, unlike genuine DID presentations, which involve complex, fluctuating identities that are developed over time. DID remains underdiagnosed and underreported, largely due to stigma and clinician skepticism. Estimates suggest that 1.5% of the US population meets criteria for DID, but many cases go undetected due to misdiagnosis. Many individuals with DID present with depression, anxiety, or suicidality rather than dissociative symptoms. Over 70% of individuals with DID attempt suicide, highlighting the urgency of proper diagnosis and intervention. Some individuals may not even be aware of their alters, while others experience co-consciousness or multiple identities are aware of each other. Because DID is deeply rooted in trauma, treatment focuses on stabilization, integration if the client desires, and trauma processing. Some approaches to this include trauma-focused therapies like EMDR, cognitive processing therapy, and internal family systems. And these can help individuals process traumatic memories while maintaining stability. Some therapies focus on internal collaboration between identity states rather than full integration, and they would do this through altering awareness and communication. And there's also pharmacological support. There's no specific medication for DID, but SSRIs, mood stabilizers, and sleep aids may help manage comorbid depression, anxiety, or dissociation-related insomnia. Treatment should always focus on long-term stability and look at reducing distress and improving overall functioning rather than forcing identity fusion if it's not the client's goal. DID is a fascinating and complex disorder that challenges many of our assumptions about the self, memory, and identity. And whether you lean towards the trauma model, the iatrogenic model, or something in between, one thing's clear. Individuals with DID deserve careful, trauma-informed, and non-pathologizing treatment. Misdiagnosis is common, stigma is real, and the ethical considerations in treatment are crucial. As we continue to learn more about the neuroscience, psychology, and lived experiences of individuals with DID, it's essential that clinicians remain open-minded, well-informed, and empathetic. Moving on to dissociative amnesia. So it's a profound and often unsettling disruption of memory where an individual loses access to significant autobiographical information, usually details tied to a trauma or severe distress. This isn't just misplacing your keys or forgetting where you parked. This is erasing entire chapters of your life, often without realizing it. Unlike memory issues caused by brain injury, substance use, or neurodegenerative diseases, the memory loss in dissociative amnesia is psychogenic, meaning that it stems from psychological factors rather than physical brain damage. Individuals experiencing this disorder often struggle to understand their own past, may have gaps in their personal history, and in some cases find themselves in unfamiliar places without any recollection of how they got there. The amnesia can range from specific events to entire periods of life, depending on the severity and type of dissociation. And according to the DSM-5-TR, the diagnostic criteria include an inability to recall significant personal information, particularly traumatic or stressful memories, memory loss that is extensive and goes beyond ordinary forgetting, significant distress or impairment in daily life, relationships, or work functioning, and it's not going to be attributable to substance use, brain injuries, or other medical conditions. And it may or may not involve dissociative fugue, where individuals travel or wander away with no recollections of their identity or past. Dissociative amnesia is often triggered by extreme stress, including abuse, combat exposure, natural disasters, or personal crises. Unlike intentional forgetting, these memories are not easily retrievable without therapeutic intervention, and some individuals may never fully recover them. If you've seen Breaking Bad, then you've probably seen an episode where Walt pretends to have a dissociative fugue. He wanders away and eventually ends up in the hospital, doesn't know what's going on. This would not meet criteria for dissociative amnesia because, like we're going to talk about in the next lecture, he was malingering. He was doing it on purpose to get something that he wanted or to get out of something that he wanted. So if you haven't seen Breaking Bad, it's a great show. There's a lot of mental health disorders that you can find in there if you're looking for a fictional character to ever practice your diagnostic skills on. But Walt does not have dissociative amnesia and does not have dissociative fugue, despite his attempts to convince people that he does. Dissociative amnesia can take different forms, affecting memory in specific or generalized ways. Localized amnesia is the most common type, where individuals are unable to recall events from a specific time period, often surrounding a traumatic incident, so maybe forgetting everything about a car accident. Selective amnesia is when the person can recall some but not all details of an event. For instance, a survivor of abuse might remember where it happened but not specific acts of violence. Generalized amnesia is rare, but a severe form where individuals lose all of their autobiographical memories, including their name, their identity, and past experiences. Systemized amnesia is memory loss that targets a specific category, such as all memories associated with a particular person, place, or event. And continuous amnesia is the inability to recall new experiences as they occur, leaving the individual in a persistent state of forgetting. So think of like 50 First Dates. Each type of amnesia presents unique challenges, making it crucial for clinicians to differentiate between patterns of memory loss to tailor effective treatment strategies. Researchers have long debated how and why dissociative amnesia occurs. Some of the most compelling explanations include trauma-related inhibition, so stress and trauma impact the hippocampus, the brain's memory center, disrupting its ability to store and retrieve information. Neurobiological suppression shows through imaging studies that are suggesting that memory suppression in dissociative amnesia involves decreased activity in frontal brain regions responsible for self-awareness and recall. And there's the protective mechanism hypothesis. Dissociative amnesia is believed to be a defense mechanism that shields the mind from psychological pain by keeping distressing memories inaccessible. Pierre Janet is a pioneer in trauma research and proposed that dissociation results from the mind's inability to integrate overwhelming experiences, causing fragmented memory storage. More recent work by researchers like Bessel van der Kolk has reinforced the idea that traumatic memories may be stored differently in the brain, making them difficult to consciously access. Because memory issues can stem from many sources, clinicians must carefully differentiate dissociative amnesia from other conditions. First off, let's talk about substance-induced amnesia. Substances like alcohol, benzodiazepines, and other drugs can cause blackouts, but these differ from dissociative amnesia in that they are related to intoxication and do not selectively target autobiographical memory. Neurological conditions like dementia, epilepsy, and brain injuries would be considered more neurodegenerative memory loss. Dissociative amnesia is reversible and not progressive like these other diseases. And again, there's this malingering or factitious disorder. So some individuals may feign memory loss for personal gain, like legal avoidance or maybe attention seeking. But the true dissociative amnesia is often ego dystonic, meaning that the person finds it distressing and confusing rather than beneficial. And then there's also PTSD-related amnesia. So while PTSD can include forgetting aspects of trauma, it does not typically result in broad memory loss or fugue states. Dissociative amnesia often emerges suddenly after a traumatic event, And the duration of memory loss varies from hours to years, with some individuals never recovering lost memories. People with dissociative amnesia may experience emotional numbing, confusion, or distress over their missing memories. Dissociative fugue often involves individuals traveling away from home, sometimes assuming new identities, only to later realize that they have no recollection of their past. Interestingly, memories can sometimes return spontaneously, particularly if a person encounters a strong emotional trigger or enters a safe, non-threatening environment. Treatment for dissociative amnesia focuses on restoring memory function, reducing distress, and addressing underlying trauma. Some effective treatment approaches include psychotherapy like CBT, trauma-focused therapy, and EMDR. These methods help recover lost memories and process trauma safely. There's hypnosis and guided memory recall, and I just want to kind of pause us here because it's really controversial. Some clinicians will use hypnosis to help patients access dissociated memories. However, these techniques must be used cautiously to avoid false memory implantation. This is not something that you will likely ever do. Hypnosis is not one of those techniques that we're going to teach. When we're weighing risks versus benefits, there's a lot more risk than there is to benefit of hypnosis, especially when we're monkeying around with somebody's memories. Treatment should also look at stress management techniques like relaxation methods, like mindfulness, grounding exercises, and biofeedback. These can really help reduce triggers that maintain the dissociation. And then there's pharmacological support. So while there's no specific medication for dissociative amnesia, antidepressants may be prescribed to manage co-occurring anxiety or depression. And many individuals with dissociative amnesia function well in daily life, even without retrieving lost memories. For some, recovery is not about getting memories back, but about integrating their present experience in a way that promotes stability and well-being. So moving on to depersonalization and derealization disorder, or DPDR. It's often described as the unsettling experience of feeling detached from oneself or the world, like watching life unfold from a distance, but still knowing that you're technically present. Unlike psychotic disorders where delusions distort reality, individuals with DPDR are fully aware that their experiences are not real, but it doesn't make the sensation any less disturbing. So there's two core components of this disorder. There's depersonalization and derealization. So depersonalization is a sense of being detached from one's own body, thoughts, or emotions. And people describe it as feeling maybe like a robot or an observer, or as if they're watching themselves from a third-person perspective. So not feeling like a person. Derealization is the feeling that the world around them is unreal, distorted, foggy, or artificial. Some individuals say that their surroundings lack depth or feel like a dream, making it difficult to emotionally connect to people and places. And according to the DSM-5-TR, the diagnostic criteria for DPDR include recurrent experiences of depersonalization, derealization, or both. Reality testing remains intact, meaning individuals recognize that their altered perceptions are not actually real, which makes it different than a psychotic disorder. Symptoms cause significant distress or impairment in their daily life, and it's not attributable to substance use, medical conditions, or another mental disorder. So an example of a medical condition here would be, I don't know if you've ever noticed that if you haven't eaten anything in a while and maybe your blood pressure feels really low, the world seems a little foggy, a little hazy, you don't really feel like the world is quite real or you're living in reality. That could be described as derealization, but it's due to not having enough nutrition or fuel in your body to make your brain function accordingly. So that would be a medical condition. That doesn't necessarily mean that you meet criteria for this diagnosis if that's happening to you and you're not eating. While brief episodes of depersonalization or derealization are common, especially during high stress or exhaustion, or like I said, maybe not eating enough, DPDR becomes a disorder when these experiences are chronic, distressing, and disruptive to normal functioning. So remember, the DSM-5-TR really loves to point out clinically significant distress or impairment. So these things might be happening. Symptoms of any disorder might be happening. But if it's not causing clinically significant distress or impairment, then it's not diagnosable. And people with depersonalization or derealization disorder often describe feeling like a spectator in their own life, as though their body is moving and speaking without their full participation. So sometimes it's really challenging for therapists to recognize it. Clients may appear functionally engaged, carrying on conversations and meeting daily responsibilities, yet inwardly feel profoundly disconnected from themselves and the world around them. So common experiences include emotional numbing or detachment. Clients report feeling distant from loved ones or described interactions as hollow or mechanical, even when discussing deeply personal matters. They might have a distorted perception of time. They might struggle to recall sequences of events, feel as though time is slowing down or speeding up, or describe days as blurring together. There can be some visual and sensory distortions too, so the world may appear flat, overly sharp, or surreal, sometimes described as watching life through a pane of glass or feeling like they're in a video game or a simulation. And there might also be existential uncertainty. Clients may express doubt about their memories, identity, or even reality itself, leading to persistent self questioning. Did that really happen to me? Am I even real? So, what this looks like in therapy, because it can be an invisible experience, a therapist might not immediately notice signs unless they actively ask. So, the client might present as flat or detached in their affect despite recounting distressing events, unresponsive to emotionally charged topics, giving logical but disengaged responses, expressing intellectualized reflections on their experiences, describing dissociation in a detached or philosophical terms, repeatedly asking for reassurance about their existence or perception of reality, which can resemble intrusive thoughts seen in OCD, or struggling with grounding techniques, reporting that mindfulness exercises make them feel even more aware of the dissociation rather than alleviating it. You might even notice something like the 100-yard stare. So it's a disconnected expression that can happen in people, kind of see their eyes glaze over a little bit and look off into the distance, looking at almost nothing at all. They're not actually present in the moment with you. So let's talk about duration and progression a little bit. DPDR symptoms can be chronic or episodic, sometimes lasting for minutes, hours, or persisting for months at a time. While some individuals experience it as a response to acute stress or trauma, others describe a gradual onset without an obvious trigger. One of the most distressing aspects of DPDR is a fear that it will never go away. Many individuals develop secondary anxiety or depression preoccupied with their altered perception. This hyper-awareness of dissociation can lead to a self-perpetuating cycle where fear of DPDR intensifies emotional blunting, making the symptoms feel even more inescapable. For therapists, recognizing DPDR requires attentive listening, active inquiry, and sensitivity to how a client describes their inner world. Because clients often struggle to articulate these experiences, creating a validating and exploratory therapeutic space is essential to helping them understand and manage their dissociation. The exact causes of DPDR remain unclear, but several theories attempt to explain its development. So again, we have the trauma and stress response. So research does suggest that DPDR is linked to the brain's overactive stress response, particularly in the amygdala and prefrontal cortex. When overwhelmed, the brain shuts down emotional processing, leading to feelings of detachment. There's also hyperactive self-monitoring. So some studies propose that individuals with DPDR have excessive self-awareness, making them hyper-focused on their own thoughts and perceptions, similar to what we see in obsessive-compulsive disorder. And then there's the cognitive perceptual disruptions. Some researchers believe that DPDR is caused by disruptions in sensory integration, altering how individuals process vision, touch, and spatial awareness. And lastly, let's talk about the neurological evidence. Brain imaging studies show reduced activity in the limbic system, which regulates emotions, and increased activity in the prefrontal cortex, which governs rational thought, suggesting that individuals with DPDR may be suppressing emotional responses to distress. Notably, DPDR is strongly associated with anxiety disorders, particularly panic disorder and generalized anxiety disorder. Some people develop DPDR after several panic attacks, while others describe it as ongoing, low-level dissociation that becomes a persistent state. Since DPDR shares features with other mental health conditions, it's essential to distinguish it from psychotic disorders like schizophrenia. In those, individuals lose touch with reality. In DPDR, they don't lose touch with reality. They recognize that their altered perception is not real, which is why it's so distressing. In PTSD, dissociation often occurs during flashbacks or in response to triggers, whereas DPDR can persist independently of trauma reminders. And while emotional numbness is really common in depression, DPDR is marked by a distinct sense of unreality, whereas depression typically involves persistent sadness and hopelessness. And hallucinogenic drugs like LSD, ketamine, and cannabis can induce temporary DPDR symptoms, but these typically resolve once the substance leaves the system. And again, there's no single cure for DPDR, but treatment focuses on reducing distress, improving emotional engagement, and addressing underlying anxiety or trauma. Some of the most effective interventions include CBT, which helps individuals challenge negative thoughts about dissociation and redirect attention away from hyperawareness of symptoms. There's mindfulness and grounding techniques, strategies such as focusing on physical sensations, engaging in the five senses, and slow breathing exercises can help reconnect individuals to the present moment. And we want to use psychoeducation. Clients should understand that DPDR is not dangerous, nor is it permanent, and it can help reduce fear-based symptom maintenance. And then there's medications like SSRIs and mood stabilizers. So there's no medication specifically for this, but some people will benefit from antidepressants or anti-anxiety medications, particularly if they have comorbid conditions like panic disorder or OCD. And some clinicians also recommend sensory engagement techniques, such as listening to loud music, holding ice cubes to bring attention back to the body, or engaging in vigorous physical activity like running or dancing to reinforce connection to movement and sensation. You can also try using scent therapy like essential oils or strong-smelling foods to activate olfactory grounding. So let's talk about other specified and unspecified dissociative disorders. Not every case of dissociation fits neatly into the categories of dissociative identity disorder, dissociative amnesia, or depersonalization or derealization disorder. Some individuals experience dissociative symptoms that cause significant distress or impairment, but do not meet full criteria for any single disorder. These cases fall under the other specified or unspecified dissociative disorders, which is just a catch-all category designed to acknowledge the complexity and diversity of dissociative experiences. These disorders can present in a variety of ways and often emerge in response to trauma, coercion, extreme stress, or cultural influences. Some individuals may have intermittent dissociative symptoms, while others may experience episodes that resemble well-known dissociative disorders but lack key diagnostic elements. So some examples of this might include chronic and recurrent mixed dissociative symptoms. So individuals may display a blend of dissociative amnesia, depersonalization, or identity disturbance without meeting criteria for DID or another specific dissociative disorder. And a fictional example of this could be Jason Bourne from The Bourne Identity. He's a character who experiences profound amnesia regarding his past identity while demonstrating highly adaptive survival skills and flashes of his prior self under certain conditions. There's also identity disturbance due to prolonged coercive persuasion. So this is seen in individuals subjected to brainwashing, captivity, cult indoctrination, or extended psychological manipulation. And a compelling fictional example might be Bucky Barnes or the Winter Soldier from Captain America. This is a character that was brainwashed by Hydra, leading to altered personality states, memory suppression, and episodes of identity confusion upon awakening from programming. There's acute dissociative reactions to stress. Some individuals may experience brief but intense dissociative episodes following extreme stress or trauma. And this could involve temporary amnesia, depersonalization, or derealization. An example of this could be Harry Potter from Order of the Phoenix, where he experiences dissociative-like episodes following his trauma with He Who Shall Not Be Named, feeling emotionally detached and struggling with identity concerns. And then there's also dissociative trance disorder. So this is characterized by a narrowed awareness, unresponsiveness to external stimuli, and altered identity or consciousness. And this condition is often culturally influenced. An example of this could be Brian Stark from Game of Thrones, when he enters deep trances as the Three-Eyed Raven, losing connection from his former identity while absorbing vast amounts of historical knowledge. So the unspecified dissociative disorders category is used when dissociative symptoms are present, but do not clearly align with an established disorder. These cases may involve atypical dissociative episodes, partial identity alterations, or unusual memory disturbances. And the diagnosis is often provisional and may change as more clinical information becomes available. And a good fictional example of an unspecified dissociative disorder might be Arthur Fleck from Joker, the 2019 version, who experiences dissociative symptoms, memory distortions, and episodes of reality distortion that don't fit neatly into any single dissociative disorder, but clearly involve profound identity confusion and emotional numbing. Treatment for these conditions varies depending on the nature, frequency, and severity of symptoms, as well as underlying causes. So common approaches include making sure that we have a full comprehensive assessment first. We want to take a full clinical history, trauma screening, and dissociation assessments. These will all help clarify the diagnosis and determine underlying causes. You can't go wrong with trauma-focused therapy. So for individuals with dissociation linked to past abuse, captivity, or psychological coercion, Therapies like EMDR, IFS, and CBT can help integrate fragmented experiences. And then there's psychoeducation and grounding techniques, teaching individuals how dissociation works along with practical strategies like sensory grounding and mindfulness can reduce distress during dissociative episodes. And again, there's no specific medication for dissociation, but antidepressants, mood stabilizers, anti-anxiety medications can help address the co-occurring anxiety, depression, or PTSD. And dissociative symptoms exist on a spectrum. Many individuals may not fit neatly into a diagnostic box, and that's probably something that you've already discovered in this class. By recognizing and validating these experiences, counselors can provide more accurate assessments and personalized interventions. Whether symptoms emerge from trauma, coercion, or cultural factors, the goal of treatment is to reduce distress, improve identity stability, and help individuals regain a sense of control over their experiences. So let's talk about etiology, and let's look at it beyond trauma because I know I've been talking a lot about trauma. And trauma is a widely recognized primary cause of dissociation. Emerging research suggests that not all dissociative experiences stem from overt trauma. Several non-trauma related factors may contribute to dissociative symptoms, including neurodevelopmental influences, genetic predispositions, and cultural or religious contexts. Understanding these broader causes can help counselors differentiate dissociative disorders from other psychiatric conditions and provide a more tailored treatment approach. Early childhood development plays a critical role in shaping self-awareness, emotional regulation, and identity integration. Some researchers suggest that dissociation may arise not only from trauma, but from disruptions in early attachment and emotional neglect. Children who experience inconsistent caregiving, emotional neglect, or disorganized attachment styles may struggle to develop a stable, cohesive sense of self. Over time, these individuals may detach from their emotions or sense of identity, leading to chronic dissociative symptoms. When a child's emotional needs are consistently unmet, their brain may adapt by compartmentalizing distressing experiences, even in the absence of overt abuse or trauma. Some individuals with neurodevelopmental disorders like autism spectrum disorder or ADHD report dissociative symptoms, possibly due to sensory processing difficulties, heightened anxiety, or challenges with self-referential processing. While not traditionally categorized as dissociative, these symptoms may resemble depersonalization or derealization. A fictional example here, she's a cartoon, but we'll look at Elsa from Frozen. She's a character who, after early childhood emotional isolation, exhibits avoidant tendencies, emotional suppression, and episodes of intense detachment from reality. Looking at genetic and epigenetic factors, let's ask, is dissociation biologically hardwired? Some studies suggest that genetic and epigenetic mechanisms play a role in predisposing individuals to dissociative symptoms. Research indicates that dissociative tendencies may have a moderate genetic component, with twin studies showing up to 50% of dissociative symptoms could be heritable. Early life stressors, even those that don't involve direct trauma, may alter gene expression related to stress regulation, memory processing, and emotional modulation. And differences in serotonin and dopamine functioning, as well as variations in amygdala and hippocampus activity, may contribute to increased vulnerability to dissociation. And dissociative symptoms do not always include pathology. In many cultures, dissociation is considered a normal or even sacred experience. What is labeled as a dissociative disorder in Western medicine may be interpreted differently in other societies. So again, I'm going to say, if there is a cultural explanation for a disorder, then it's not a disorder, it's culture. So let's talk about spirit possession and trance states. In some cultures, dissociative states are intentionally induced during religious rituals, trance ceremonies, or healing practices. So these would involve altered identity states without distress. And while the identity state is altered, it would not meet criteria for a diagnosis. The ICD-11 does recognize possession trance disorder as a diagnosis that accounts for dissociative symptoms occurring within a cultural or spiritual context. And I'm just curious what you have to think about that, because the DSM, for once, has decided that cultural contextual symptoms equate a disorder, and yet the ICD-11 does recognize this. Understanding the broader etiological factors is essential for accurate diagnosis and effective treatment. By considering the possibility of non-trauma related dissociation, counselors can avoid over-pathologizing cultural and religious experiences, recognize the role of attachment and neurodevelopmental factors in dissociative symptoms, and consider genetic predispositions while assessing vulnerability to dissociation. You can also tailor interventions to address the unique origins of each individual's dissociative experiences. So dissociation is far more than a response to trauma. It's part biology, part development, part cultural, and part individualized meaning. By broadening our understanding of why dissociative symptoms emerge, we can develop a more nuanced, compassionate, and effective clinical approach. Next, we're going to talk about the intersection with other disorders, aka comorbidity, and let's also talk about misdiagnosis here. Dissociative disorders rarely exist in isolation. They often overlap with other psychiatric conditions, making accurate diagnosis challenging yet essential for effective treatment. Symptoms like memory loss, detachment from reality, or identity confusion can resemble aspects of PTSD, borderline personality disorder, obsessive compulsive disorder, and even psychotic disorders. One of the most frequent areas of diagnostic confusion is between dissociative identity disorder and PTSD with dissociative features. Since DID is strongly linked to trauma, some clinicians may mistakenly diagnose severe PTSD with dissociation as DID. The key difference is for PTSD with dissociation, this is going to involve emotional numbing, flashbacks, and dissociative episodes, but the individual retains one unified identity. Dissociation in PTSD is often situationally triggered by reminders of the trauma. DID, however, involves two or more distinct personality states with amnesia between identity shifts. Unlike PTSD, DID includes identity fragmentation, where different alters may have unique voices, memories, and perspectives. And then there's borderline personality disorder, which frequently co-occurs with dissociative symptoms, leading to misdiagnosis between BPD and DID. And key distinctions are in BPD dissociation. It's typically brief, stress-induced episodes of depersonalization or derealization, that feeling emotionally numb or detached after an interpersonal conflict. Individuals with BPD do not experience separate identities, but may feel unstable in their sense of self. For DID, this involves discrete identity states with different thought processes, emotions, and even physical reactions. Dissociation in DID is more persistent and complex than in BPD. Though OCD is not traditionally linked to dissociation, some individuals experience derealization or depersonalization as part of their obsessive-compulsive cycles. There's hyper-awareness in OCD, where some individuals with OCD become hyper-focused on their thoughts, leading to a sense of detachment from reality. For example, somebody obsessively questioning, am I real? What if I lose control? May start feeling disconnected. Dissociation in OCD versus DPDR. So unlike that depersonalization and derealization disorder, where dissociation is the primary symptom, in OCD, it's secondary to intrusive thoughts and compulsive reassurance seeking. And one of the most crucial distinctions is between dissociation and psychosis. While both involve altered perceptions of reality, the key difference is in reality testing. Individuals with dissociative disorders remain aware that their experiences of detachment, amnesia, or identity shifts are unusual and they're creating distress. For psychotic disorders like schizophrenia, individuals lose touch with reality and may have delusions or hallucinations that they believe to be real. Misdiagnosing dissociative symptoms can lead to inappropriate treatment, such as prescribing antipsychotics for dissociation that's not a psychotic disorder in nature, or overlooking trauma in cases of PTSD misidentified as DID. Counselors must assess for identity continuity. Is there a single unstable sense of self? That would be borderline. Or are there multiple separate identities? Dissociative identity disorder. You want to distinguish between dissociation and psychosis. Does the individual question their altered perceptions? Dissociation. Or believe them without insight? That would be psychosis. And then you want to evaluate for secondary dissociation. Is detachment a primary symptom, like in DID or DPDR, or a secondary response to anxiety, OCD, or PTSD? So by refining diagnostic criteria and recognizing the nuanced ways that dissociation presents across disorders, counselors can ensure individuals receive the most effective and appropriate care, which is what we're actually here for, right? We're not just here to diagnose and move on. We're here to diagnose and treat. So let's talk about functionality and the adaptive aspects of dissociation, because dissociation is often viewed through a pathological lens. But if we sort of flip the script here and look at it from a Gestalt perspective, it can be also understood as an adaptive, protective, and even creative response to life's challenges. At its core, Gestalt therapy emphasizes awareness, choice, and intentionality, encouraging individuals to integrate disconnected experiences into a cohesive whole. Rather than simply being a symptom of dysfunction, dissociation can be seen as a strategy for survival, self-preservation, and meaning-making in the face of overwhelming emotions or stress. So not all dissociation is pathological. In fact, mild dissociative states are common parts of everyday life. Many people engage in automatic behaviors where they temporarily zone out but continue functioning effectively. So like highway hypnosis. Have you ever driven home and suddenly realized you don't remember the last several miles? Your brain was operating on autopilot, allowing you to perform a complex task while focusing on internal thoughts. We can also look at creative flow states. Artists, musicians, and writers often enter a trance-like immersion in their work, losing track of time and surroundings. And this flow state shares elements of dissociation, yet is highly productive and rewarding. And then there's also emotional buffering. During difficult conversations or distressing situations, people may momentarily detach from their emotions to remain composed and think clearly. And looking at it from a Gestalt perspective, these moments of dissociation are not disorders. They're part of the natural rhythm of human experience, a fluid movement between engagement and withdrawal, presence and distance. The key question is whether dissociation enhances adaptability or limits choice and intentionality. For individuals who have experienced chronic stress or trauma, dissociation can serve as a psychological partitioning mechanism, allowing them to navigate life without being constantly overwhelmed. While DID and severe dissociation can create challenges, the ability to compartmentalize difficult emotions or experiences can also provide structure, stability, and coping mechanisms. So looking at compartmentalization as a survival skill. Many individuals with DID report that their identity states or alters formed as a way to separate overwhelming emotions and memories, allowing them to function in daily life. Some people learn to switch off emotional responses to high-stress environments, like maybe emergency responders or military personnel. And this ability to dissociate on command can help them perform their duties without being paralyzed by fear or anxiety. And instead of seeing dissociative states as a loss of control, Gestalt therapy encourages building awareness around these states, recognizing them as functional responses to past or present experiences, and exploring intentional ways to integrate them into a healthier self-concept. Gestalt-oriented approach to dissociative experiences emphasizes choice. Can the individual engage or disengage intentionally? Can they bring awareness to dissociative moments and explore what purpose they serve? Dissociation becomes problematic only when it limits self-awareness and autonomy, rather than serving as a temporary adaptive strategy. And dissociation is not universally seen as pathological. We already talked about some cultures, trance-like states, possession experiences, altered consciousness, and these are embraced as part of spiritual or religious healing practices. So we might want to ask ourselves, does this dissociative state create distress or is it meaningful? Is it voluntary or involuntary? And does the individual have agency in navigating the states? And these questions can help avoid Western-centric bias from diagnosing dissociation and ensures that cultural context is respected in clinical assessments. So Gestalt therapy, rooted in the idea that healing occurs when we bring awareness, choice, and integration to fragmented experiences, this is going to directly apply to dissociation. Instead of fixing dissociation, we explore what it reveals about the person's experience. Instead of assuming dissociation is inherently pathological, we ask what function it serves. And instead of forcing normalization, we help individuals build agency over their dissociative responses. For many individuals, learning to recognize dissociative patterns deepens self-awareness and develop greater choice in their experiences can transform dissociation from an automatic escape into an intentional coping tool. By fostering curiosity rather than fear, Gestalt therapy encourages individuals to reintegrate their dissociative experiences into a fuller, more embodied sense of self. Treating dissociative disorders requires careful ethical considerations, clinical expertise, and an individualized approach. While some therapies aim for memory recovery or personality integration, others focus on stability, symptom management, and client choice. Several key ethical and practical challenges arise in treatment planning, the first being ethical issues in recovered memory therapy. So the reliability of repressed or recovered memories remains a major controversy in dissociative disorder treatment. Some clinicians use hypnosis, guided imagery, or regression therapy to help clients access dissociated memories. However, research by Elizabeth Loftus and others has demonstrated the risk of false memories, which can lead to misattributions of trauma and legal or emotional consequences for clients and their families. Many trauma-informed therapists avoid direct memory retrieval techniques, instead emphasizing grounding, stabilization, and validating the client's present experience rather than restructuring uncertain past events. And for individuals with dissociative identity disorder, a key ethical question is whether therapy should focus on integrating alters into one cohesive identity or fostering cooperation between them. While earlier models emphasized full integration as the goal, many clinicians now recognize that not all individuals with DID want or need to merge their alters. Instead, a collaborative approach where different identity states learn to communicate, negotiate, and coexist without distress may be a more practical and client-centered outcome. Treatment should align with the individual's goals, whether that means integration or a functional multiplicity model where alters work together to create a stable life. And despite the prevalence of dissociative disorders, many clinicians lack formal training in recognizing and treating them. Misdiagnosis is common, with many individuals receiving labels of borderline personality disorder, schizophrenia, or bipolar disorder before dissociative symptoms are accurately identified. Additionally, therapists may feel unprepared to handle complex dissociative presentations, leading to undertreatment or avoidance of dissociative clients altogether. Increasing clinician education, specialized training, and interdisciplinary collaboration is essential to improving diagnostic accuracy and treatment outcomes. Dissociative disorders challenge our understanding of identity, memory, and perception, requiring nuanced clinical approaches that move beyond simplistic views of pathology. While dissociation is often linked to trauma, we explore broader contributing factors including neurodevelopmental influences, genetic predispositions, and cultural interpretations of altered states. Understanding these perspectives helps to differentiate between adaptive dissociation and clinically significant distress. Each dissociative disorder presents with unique diagnostic and treatment considerations. Dissociative identity disorder, aka multiple personality disorder, involves identity fragmentation, where dissociative amnesia centers on memory loss beyond ordinary forgetting. Depersonalization and derealization disorders affect perception of self and reality, often leading to profound distress. Some individuals experience dissociative symptoms that don't really fit neatly into diagnostic categories, reinforcing the importance of individualized assessment and treatment. Dissociative symptoms also intersect with other psychiatric symptoms, leading to frequent misdiagnosis. From a Gestalt perspective, dissociation is not inherently dysfunctional, but can serve as a protective, adaptive mechanism. Many dissociative experiences allow individuals to navigate distress, maintain emotional equilibrium, and function under pressure. Recognizing both the functionality and limitations of dissociation encourages a more compassionate, client-centered therapeutic approach. And ultimately, the ethical landscape of dissociative disorder treatment is complex and evolving. Counselors have to balance validation with caution, therapeutic goals with client autonomy, and clinical expertise with ongoing learning. By prioritizing client safety, informed consent, and individualized care, ethical treatment approaches can support individuals with dissociative disorders in reclaiming agency over their experiences without imposing outdated or one-size-fits-all solutions. Informed, flexible, and empathetic approach allows clinicians to honor the realities of dissociative experiences while empowering individuals to achieve stability, integration, or functional adaptation, whichever goal best aligns with their needs. Thanks so much for hanging out with me today. If you have any questions, drop them in the comments below. I'm excited to see what you guys think of this.